Yes, you're right. We should start by that, by acquiring images, because the better the images, the better the service that InHeart can provide, obviously. So there are numerous ways of acquiring imaging of the heart, and the InHeart solution incorporates most of them. Here is a slide that shows the most available technique, which is arterial enhanced CT. So it's the same thing as a coronary CT, except that the injection protocol is slightly different because we need enhancement in both the LV here and the RV in order to visualize also the right ventricular structures and the thickness of the septum. But apart from that, it's a very standard cardiac CT acquisition. The only differences with respect to classic cardiac CTs is first this injection protocol, which has to be slightly modified, but the InHeart team can assist you in doing that. Then there's the coverage also. We need the aortic arch or the pulmonary arteries, and you will see why. Pierre will tell you that these are critical structures to obtain optimal registration during the procedure. And then we need these to be acquired during mid-diastole, meaning that it's the maximum volume, so the volume matches well with electroanatomical mapping systems. And in this very standard acquisition, there's a lot of information. There's a lot of anatomical information, but also substrate information. We can extract from these images maps of wall thickness, maps of intramural fat or calcification, and this helps us guiding catheter ablation in most patients, particularly in post-infarction patients. In some patients, there are intramural scars in areas with preserved thickness, and in these, we need late enhancement imaging. And for that, the best way to go is to use MR. So this is the second method that I will show, is the late enhancement CMR technique. So this is a technique that maps the accumulation of gadolinium and the late phase in the scar because there's less viable tissue. So the distribution of the gadolinium is, the volume of distribution is higher and the concentration is higher. But if you ask that to your imaging department, most of the time they will do this, which is the conventional way of doing late GAD-MR. It's during one breath hold, you acquire images of the heart. The spatial resolution of that is limited. The slice thickness can go up to 8 millimeters. So the description of the scar will be quite limited also. There's another way to do it, is high-res three-dimensional late GAD-MR. And this is a different technique that is acquired during free breathing thanks to a monitoring of the diaphragmatic motion. And this gives access to much lower spatial resolution in the range of 1 to 1.5 cubic millimeters. And this is the way to go if you want a detailed scar characterization in your lab. So again, the InHeart team has protocols for most vendors of CMR systems and can assist your imaging teams in developing these. The problem with MR is that very often there are ICD artifacts, and these images are heavily hampered by these artifacts. For that reason, we are often implementing in centers late iodine-enhanced CT. So it's the same thing as late GAD-MR, but with CT. You see here an arterial phase CT, here a late iodine-enhanced CT showing an inferior infarct. These two images can be fused and you can have the spatial resolution of the arterial CT and the late iodine CT showing the scar distribution. And this matches very well with the scar as mapped from MR. So again, there are multiple ways of accessing the scar. Arterial enhanced CT is easy, doable everywhere, and answers the question for the majority of patients, but sometimes you need late enhanced imaging, either with MR or with CT, depending on the presence of ICD artifacts and the availability of the methods in your center.